Thank you, Kate and Christoph. So financial disclosures, I'm not being paid to be here. I do this because I actually love sample collection and things like that. I'm a salaried physician. I also give advice to the Ontario government so they don't let me travel on anyone else's dime anymore, which is kind of too bad. No other disclosures. This is the original Likert scale of Plato of 2,500 years ago. So wise men speak because they have something to say, fools because they have to say something. So remember when you're filling out your evaluation, it goes from fool to wise, and hopefully I'll be at least in the middle or higher. I have three objectives in the next 15 minutes: to discuss optimal collection and preservation of specimens for respiratory virus testing, for gastrointestinal pathogen testing, and to look at some other anatomical site testing. So we'll start with respiratory viruses. They've been both the good and the bad of our existence for the last 3 years, but I've spent over 20 years looking at influenza and RSV and other respiratory viruses, particularly from the pre-analytic point of view. How do we better collect? How do we better preserve? Because a lot of the debate in the literature has been about what test we apply to it, but I would suggest that it's equally important that we collect and preserve that well. And of course, that's really come to the fore during SARS-CoV-2, especially when we ran out of every swab type and every medium type and had to multiply test every new swab. And I don't know about you, I've had at least 100 swabs up my nose as part of those endeavors so that we can safely do things for our patients. In the original years, it was always nasopharyngeal aspirates, and most of us have got away from that as being messy and a biohazard, but certainly nasopharyngeal swabs have become the standard for both pediatric and adult throughout most of the world. But through COVID and in our lab for many years before, we looked at alternate specimen types as well, things like nasal swabs, throat swabs, mid-turbinate swabs, which I'll discuss a bit. We've heard earlier this morning about things like saliva. We've also done oral swabs, and of course, sputum. So the issue, though, is how to actually show that these work properly. And so we obviously want to detect infection, but when you have low prevalence of virus, you may have to study hundreds, even thousands of people to do that well. So can we have surrogate measures so that we develop methods of swabbing that tell us we're likely to succeed or likely not to succeed? And so one of our first measures was epithelial cells of nasopharyngeal swabs. We did this because we used to do direct fluorescent antibody and antigen testing in our laboratory, and we automatically quantified cells to tell you that you had a lousy specimen or a good specimen. And then we developed things like beta-actin. Other labs have done that as well, and we showed beta-actin was an almost perfect proxy to respiratory epithelial cells with an R-squared of about 99. And then more recently, many of us have been doing RNase P as an adequacy control in our COVID testing. And so the important concept is you need a quality measure of sampling effectiveness. And if we're going to improve sampling, somebody's got to develop that measure. I think it's well developed for nasopharyngeal and nasal swabs. It's actually poorly developed for most of the other types of specimens we're going to talk about. Secondly, when the flock swab was invented back in about 15, 20 years ago, we had a perfect opportunity to try to understand what's the relationship between quality, the number of cells, the number of infected cells, and how to then diagnose a greater proportion of patients. And so we performed this study initially on volunteers. So when the flock swabs first came out, we took laboratory volunteers, we randomized order of different swabs, and we performed not just nasopharyngeal swabs, but I was also curious about nasal swabs. So in each of those graphs, what you see on in the red is the nasopharyngeal swab done with the old swab. That's the conventional rayon swab. You can think of it like a cotton wrapped around, it's actually nylon wrapped around a wire, versus the flock swab, which you can think of like a brush, perpendicular nylon fibers at a 90-degree angle. And essentially, you're just brushing the nasopharynx better and therefore getting more cells. And so we had two people in the lab independently count the cells, blinded to which swab it was, and we could show a highly statistically significant 50% improvement in the number of cells. If you now turn your attention to the blue part of the graph, here are the nasal swab sampling. So the nasal swabs, the same swab but sampling in the nasal site, did not sample as many cells, but the better swab sampled more cells. So it had us lead to the hypothesis that could we improve sampling the nose by sampling more cells from the nose? So we actually sent one of my master's students to the cadaver lab. We measured cadavers and their mid-turbinate bones and came up with distances and so on. And then we spent about 2 years developing a better swab, which simply asked the question, can we better and comfortably sample the number of cells? And if so, can we approximate the quality of a nasopharyngeal swab? And so we wanted to simply increase surface area, increase the cells collected, and therefore give us good sensitivity. We also wanted to develop something where people could self-collect. It's hard to self-collect a nasopharyngeal swab, but we wanted to be able to self-collect mid-turbinate swabs. We also felt then parents could collect from their children more comfortably than a medical worker, and we could also, very importantly, quantify and do repeat collection. So this is the swab that we developed. It's called the mid-turbinate swab. And we've done this in many, many studies, but it's also been used in clinical trials of antivirals, where this is done serially, and then the area under the curve is the measure of antiviral activity. And so that's been done both for influenza antivirals as well as for RSV antivirals. And we've done this in a number of cohort studies. We've done probably about 10,000 of these in various self-collected studies. This was back in swine flu 2009, 2010, where we had university students living in residence self-collect every week. And then we looked for not only influenza, but seasonal coronaviruses, RSV, etc. And in fact, we mostly found rhinovirus, although we certainly found influenza as well as seasonal coronas. The other thing I mentioned is if you can get a good quality reproducible specimen, you can do this serially, and you can do this particularly if it's easy to collect. So these are 3 patients self-collected at home, influenza viral loads back again 2009, 2010. First patient there started with log 8 of virus, and within a day had no detectable virus. He's the one that we treated with oseltamivir. 21-year-old, straight off the plane, had gone to Mexico for a nice vacation and came back with swine flu. The other 2 were not treated because public health decided nobody was allowed to treat with oseltamivir except if you were a high risk of hospitalization. So in fact, this was a couple that infected one the other, and the one person worked with elderly people. And although we had no empiric basis to know when you're infectious and when you're not, at day 8, the person was going to go back to work with elderly patients with cognitive impairment, and on the basis of these viral loads, we said, please don't do that. You may well infect other people. So again, it's not just diagnosis. More and more we need tools that can quantify, because those may be important prognostically, they may be important in terms of antiviral responses of drugs and so on. Now this is actually a study that I did on myself. I gave a talk at a virology symposium last May in Florida, and courtesy of Florida and a lack of any sort of precautions, I came back with COVID. I took the precautions, nobody else did, but I came back from COVID. So I stayed home for 14 days, got 50 swabs in various transport media, and performed experiments for the betterment of humanity. So this is one of those. This was 14 days, same time every day. I did a mid-turbinate swab. And here you've got log E gene, so basically going from about log 6 or 1 million copies. And what you can see is a slight increase for the first few days, a stabilization, and then a rapid decrease. Now, I'm going to get better. I'm not immunocompromised. I've had my 4 shots. But you can imagine doing this with patients who have a transplant or get remdesivir or get Paxlovid and so on. This allows you very easily to do serial viral loads and to understand what's happening to individuals. And this is probably my favorite slide. These are 5 swabs. I actually took 10 swabs because I took them with and without antigen. These are 5 swabs I took about a minute apart in the order that you see. And so on the left-hand side, you have an anterior nasal swab. Now, the kits we get, we all in Canada got, gazillions of these antigen kits. I've probably done 30 antigen tests on myself and about 100 PCRs. But it's a nasopharyngeal swab, which is not designed for the anterior nose, but we're all supposed to self-collect in the anterior nose. And so this is what happens. You get a very, very faint bar over here. Sorry, I don't know if I've got my mouse there. Sorry, I'll go back one. So if you see here, the T line is your antigen. You get a very, very faint antigen. A minute later, I'm doing a nasal swab, so I'm doing a stiffer swab in the nose, and I get a better line. Then I do an oral nasal, mouth and nose. Finally, I do the mid-turbinate, and I get my daughter, who's now a trained paramedic, to do a nasopharyngeal swab. The first 4 self-collected. The final one is professionally collected. And you can see that T-line goes from very, very faint to much, much stronger. If you look at the bottom, the E gene and log base 10 goes from 3 to about 4.5. So about a 1.5 log difference. Same nose, probably same amount of virus, but a different swab and a different sampling technique. And then if you look at the CT values, you can improve the CT value by 6. We spend a lot of time comparing different tests to get a log to 1 log, half log improvement. Most of the commercial companies out there spend all of their time on the CT value. Very few of them spend time on trying to improve the swab and how to collect it. And this is then stability. So this is a different concept, but when we have a swab, we want to self-collect it, and then we want to preserve that. And we want to preserve it at least for 24 hours if you're offering, quickly getting it to the lab and so on. But a lot of the time, if you get overwhelmed, it may be several days before a swab was processed at the peak of COVID. Now, this isn't COVID. This is influenza. This is a mock study. But what we did is we took cultured influenza virus, used a swab with various transport media. We did this multiple times at multiple temperatures. And what we can show is that viral transport media like VTM, UTM, and so on, pretty stable at room temperature for at least a week, very stable refrigerated or frozen out to at least 3 weeks, but deteriorate fairly quickly within days if they're stored at 37 degrees. We looked at alcohol-based media. We also looked at no medium at all. Today we would have repeated this with a molecular medium, and we've done that. Molecular media give you something even better than the viral transport medium. You have essentially no fall-off at about 7 days, even at 14 days of the molecular medium. So then let's turn our attention to gastrointestinal pathogens. We've discussed respiratory pathogens, but here I want to focus a bit more on the medium that we might use. So gastrointestinal pathogens may be bacterial, Salmonella, Shigella, Shiga toxin-producing E. coli, etc. And many of us have gone to molecular methods rather than culture. It's more sensitive, it's quicker. But you can use one of 3 things. You can use bulk stool, basically poop, put it in a container, send it to the lab. Great, except if it leaks, not fun to collect. You can actually swab the stool. So rather than sending in stool, send me a swab in a medium. That's a lot tidier for me to deal with at the lab end. It may also be easier to collect. You can swab a diaper from a child. You can perhaps even swab the rectum. And that's the third thing. You can actually do a rectal swab. And the advantage there is you can collect it at that time. On the other hand, there's an invasiveness to collecting a rectal swab, whereas when you send them with a container to get their own poop, we're not exposing them to what can be maybe occasionally an uncomfortable thing. At the same time, it's more immediate, and I'll show you in a moment. It may be actually better than a stool. Now, this is a study one of my postdocs did in our lab where she took various viruses and bacteria and using an assay, here we're just showing you CT values, so the higher the worse, the lower the better. And if you just look at bulk stool, meaning poop in a clean plastic container, versus the 50 microliters of the fecal swab is essentially just Kerry-Blair. It's a good medium for molecular as well as for culture if you need to culture. And what you can see is essentially that first and third bar from each of those organisms is essentially the same. And we've published this in JClin Micro. So basically you can swab stool, put it into a medium like Kerry-Blair, and get equivalent results to getting the stool sent to you. But you can also swab the rectum itself directly, and this is a study done by David Goldfarb. We did this together in Botswana on children hospitalized with diarrhea at the Princess Marina Hospital in Gaborone, Botswana. And so what David designed with several of us is a short 3 centimeter from the tip to the stopper, a flocked head. This would be inserted when children were seen in the emergency department. And on average, we were able to get a specimen 2.5 hours quicker than if you waited for a stool. And we even had children dying of diarrheal disease where there was never a stool passed. And so it actually allowed us to figure out what were the common causes of diarrhea in Botswana. And this is from the paper that resulted, and if you can ignore most of it and just focus on the 2 arrows. For bacterial pathogens, we would have been happy to have an equivalent, a 95%. Well, we actually found the swab was better than stool. So 93% sensitive compared to about 70% for stool. This was quite surprising. It suggests that a lot of these pathogens were found in the rectal cells themselves, and certainly we were quite surprised, but other groups have looked at this as well. Viruses, it was slightly worse, but still comparable, but the two together, we can say that the rectal swab at least as good, probably better, and a lot faster, quite comfortable, and in the setting of a hospitalized child, quite easy to justify doing a really good test like this. And then you can extend some of these concepts to other anatomical sites. We've done oral swabs, both for antibodies as well as for DNA collection for things like mononucleosis. We've done throat swabs, still having difficulty figuring out what the right marker is, because we've tried to do self-collection studies for throats, and we can't quite figure out whether bacterial or human markers work better. Neither of them work as well as they do for respiratory. For skin lesions, we had patients with Mpox who would self-sample their lesions. So again, what would be the marker to tell you that you've got a good swab? And finally, of huge interest is for STI testing. In my HIV clinic, most people self-test. They'll do a urine, that's easy, self-collected vaginal, self-collected rectal. Although for throats, we still have nurses do those. We're not yet convinced patients take a well-collected throat swab. So just to conclude, we've talked about what's the optimal sample type. Obviously, you've got things like nasopharyngeal or bulk stool, but is there something that's easier to collect? Can we enable self-collection? And what's the appropriate quality marker if we're going to do that? We've talked a little bit about type of transport medium. We want to maintain integrity, ideally have a leak-proof container, and the smaller the better, and then something that'll aid in extraction processing. So I'll conclude with that. I wanted to thank Santina Castriciano, who taught me a lot of the virology I know and worked with me on a lot of these projects, and the late Daniele Triva, who was a very enthusiastic supporter when we developed with him the mid-turbinate swab many years ago. Thank you.